Before we dive into the content of today's session, I'd like to share some background on the project, which is Knowledge Success, that brings you this webinar today. For those who may not be very familiar with the project, Knowledge Success is a global project funded by USAID Office of Population and Reproductive Health. This project is a consortium partnership, and it is led by Johns Hopkins Center for Communications Programs in partnership with Amref Health Africa, Busara Center for Health Economics, and FHI 360, and has regional teams in Asia, West Africa, and East Africa, where I'm from. We are a knowledge management project, and our objective is to help countries and programs learn more, share more, and do more. Our work primarily focuses on family planning and reproductive health. However, we also provide knowledge management support to other health programs. We help individuals, programs, and organizations, and even countries collect knowledge and information, organize it, connect others to it, and make it easier for people to use so that they can share the experiences of what works and what doesn't, and learn from each other. We work with stakeholders to develop innovative and localized tools that improve the exchange and flow of information. We also publish practical evidence and insight on ways that are actionable and easy to understand, and you can find this on our website. Today, we are pleased to bring together a distinguished panel for our conversation on the link between family planning and menstrual health. It is my pleasure to introduce the three speakers for today, and we'll start with Tanya Mahajan. She leads the international programs at the PANT project, where she oversees a portfolio of menstrual health programs in low-income settings. She has over 12 years of experience in market development of health products and services in low and middle-income countries, and has led research and program on menstrual health from an intersectional lens. She also drives evidence-based advocacy and informed choices in quality. Next, we have Dr. Marston Solomon, who is a consultant gynecologist and obstetrician with over 30 years experience in reproductive health and family planning and maternal, newborn, and child health service delivery. He has experience providing overall technical insights and leading teams of committed and highly skilled technical personnel in various maternal, newborn, child, and health family planning technical components. He is currently working as a consultant for selected family FHI program, FHI 360 projects. Our final speaker and presenter today will be Emily Hopes, who is the Senior Technical Officer in the Product Development and Introduction Department at FHI 360, where she focuses on research, utilization, and product introduction. Through this, she manages the Contraceptive Technology Innovation Exchange, a knowledge-sharing platform for contraceptive research and development. And she works on integration of family planning and menstrual health with a focus on the issue of contraceptive-induced menstrual changes. You must agree with me, this is a very, very qualified panel, and we're looking forward to hearing what they'll have to say today. So before we begin, a bit of an introduction to the topic of discussion. The intersection of family planning and menstrual health is a crucial yet often overlooked aspect of reproductive health. These two domains are intricately linked, influencing each other in ways that significantly impact the well-being and empowerment of individuals, particularly women, and as a holds in lists and complement of reproductive broader context.
Hi, everyone. It looks like Irene is having a bit of technical issues. So while she works on those, I will jump in. And Irene, if you are able to unmute and see if your sound is working, please let me know.
Yes, my sound is
okay.
working now.
Okay, go ahead.
I am so sorry about that. I hope you got a bit of what I was of the introduction. Apologies about that. So to take us off and to start us off on this interesting dialogue, and it's a kind of conversation, I would like to welcome Tanya and Dr. Solomon to speak to us about the link between family planning and menstrual health. So, Dr. Tanya and Tanya and Dr. Solomon, I know that you have years and years of experience practically working in this sector and meeting so many people. I have 3 questions for you, and you can take the cue whenever it is that you feel comfortable. So this field, family planning, reproductive health, and menstrual health, they are very complex, as I explained before. And in their complexity, they are also diverse. With your experience in the field, if you could identify 1 or 2 core principles or concepts that underlie your field, what would those be, Dr. Tan?
Dr. Solomon, I think you're on mute.
Yeah, so thank you so much, Irene. Let me go first. Yeah. So what are the concepts that, which is relates to family planning? The concept that really resonates well is really the whole aspect of volunteerism. People must be able to make an informed decision. This means that they are provided with the information about all the methods available and are allowed to make a choice that best fits their lives. So it's really they make this decision without any forms of coercion, and that is which really represents one of the hallmark of family planning. The other one is actually family planning is rights based. It's the client has a right to make a decision on the number of children they want to have, the interval between the pregnancies, and the timing of pregnancies. It is not the right of the service provider or anyone else to make those decisions. And the other third, pillar or area that really is with family planning is that family planning is a multi-sectorial in nature. It's not just a health issue. It is not just for health intervention. It goes beyond into other non-health sectors and disciplines, and this includes education and also the environment. Yeah, so those are the 3 that really crossed my mind.
Thank you
Over.
so much, Dr. Solomon. Thank you so much, Dr. Solomon. Tanya, when looking at all things menstrual health, what is your take on this?
Yeah, I mean, first of all, thanks to Knowledge Success, I think, for hosting this conversation. I think this itself is, in addition to the work that FHI 360 has been doing, is a step in the right direction for looking at this integration. And so really congratulations to you guys for hosting this. I think I would like to build on what Dr. Solomon said. I think one principle that's common between both menstrual health and family planning is the multi-sectoral lens, because even as an outcome itself, menstrual health requires the lens of awareness, access to facilities, access to products, waste management, health services, etc. So even as an outcome itself, it deals with or intersects with a wide variety of sectors, which often operate in silos, but there is an effort to find that intersectionality. And on the other side, as an input, it intersects just like family planning with so many sectors, whether it's education. Menstrual health is key to contribution to school engagement and participation, to sexual and reproductive health outcomes, which we'll be talking about a little more today, and Emily will be sharing through her presentation, to gender-based violence. One example being the experience of those who menstruate, as they in wash facilities, they are more prone to gender-based violence. So truly, I think menstrual health is multi-sectoral and intersectional, and really builds from family planning on that. Second concept, I think, that underlies any of the work that's happened in menstrual health is just the feminist approach to menstrual health, and which basically, and this is something that I've really learned over recent times through support from colleagues, conversations that have happened at the Global Menstrual Collective, etc. How menstrual health is a result of giving voice to user needs. It started from the wash sector. Menstrual health did not start in SRHR, we all know. It came from the wash world, but it saw the light of day because user experiences around use of wash facilities during menstruation were heard. But that was just the starting point. The sector has taken the work forward in defining menstrual health much more holistically, centering it as a health and human rights issue, that influences people across their reproductive life cycle, with wash experience being one of the components. So the feminist approach, I think, to menstrual health is key. And the third is body literacy for advocacy amongst users, is important across all aspects of menstrual health, whether it's access to products, awareness, waste management, because it is through body literacy that stigma around menstruation can effectively be addressed. But this knowledge does not effectively always translate into change in attitudes and practices without engagement of stakeholders across different levels of influence. And that, I think, again, is a concept that overlays along with the family planning world.
So much. That's quite interesting. My second question to you, Dr. Solomon, what do you think the field of family planning should learn from, the fields of family planning and menstrual health should learn from one another or do to build up and support one another through the integration? We've already acknowledged the multisectoralness, the multisectoral aspect of these two fields. So what do you think we could learn from each other to build and support one another through the integration?
Yeah, thank you so much, Irene. Actually, family planning in some cases of method provision, do rely on the menstrual cycle awareness. And for example, when we take into consideration a method called the fertility awareness method, that is an example of that is the standard days method. Here, this method, for it to be practiced effectively and for it to remain effective, it actually relies on a menstrual cycle length of should be between 26th day to 32 days. If it is less than that, or if it is more than that, then it's not going to be a very effective method. So the reliance of menstrual cycle length and having the couple be aware of that, so that they can be able to time the use of that particular method is what I can also cite as a good indication for that indicates that there is that connection between family planning and the menstruation or menstrual cycle. To provide proper education and counseling so that this menstrual cycle can be understood by the clients is very important. And that is a good opportunity for the counselor or the provider to provide this information and to enable the client and the couple to learn about the menstrual cycle and menstrual health. Yeah, so that's one. The other one is that there are these in relation to the contraceptive-induced menstrual changes. So these are basically all the menstrual changes that occur as a result of use of contraception, and which actually to many clients it causes concern to them. Matters to do with bleeding is really a concern to patients and clients, and really if it's not taken care of very well, the clients are not counseled properly, then it normally leads to discontinuation and also maybe even non-use. So counseling tools are important to provide information and address this concern. For example, the use of the normal tool. Then there is the connection between the connection between menstruation and family planning, in the sense that for those who want to time the menstrual cycle in a manner in which they would result in conception, the menstrual cycle regularity will be a pointer to indicate at least ovulation do take place, and therefore they will be able to time the sexual intercourse to be timed around the time when fertility ovulation is actually would be predicted to be taking place, usually between the 10th to the 19th day. So when one does have regular cycles, then that's a pointer that ovulation does take place, and most likely in the range that I have mentioned. So that's the connection. And what can be done?
Thank you so much. Flipping over to the menstrual health side, Tanya, where do you think the intersection lies?
So I think I'll speak to what Dr. Solomon just shared right now, because I think there is more that menstrual health can do to support the family planning and SRHR fields overall in this work. So family planning does deal with all of these issues from the point of view of the woman who is of reproductive age. However, I think a lot of that still happens without addressing some of the foundational stigma around menstruation and having some of those foundational conversations around the biology of menstruation, and without which, honestly, I think FP conversations, whether it is around fertility awareness methods or counseling of couples, it's almost like jumping to the next step without really taking that baby step of learning the alphabet first. So I think looking at menstrual health as the gateway to conversing about SRHR across age groups, across different types of stakeholders, is somewhere that menstrual health can support the family planning space. As an example, I have been in conversations with women who have had 3-4 children and do not know that they have 3 holes in the female human body. We have witnessed couples, where the husband first heard about periods when he witnessed his wife having her first period. So how can you counsel such a couple about family planning without imparting body literacy first? So and there's huge potential in exploring that sort of formative space as a foundational first step to FP and SRHR work. Also, I think menstrual health can be an anchor to look at the health of women beyond just their reproductive years. This is for the SRHR field overall, going beyond FP. We've seen women who are ready or who have had hysterectomies because of recurring RTIs, or because they're having menstrual bleeding or pains or issues which don't necessarily require hysterectomies. There's really disturbing data, I know from India at least, that's showing really high rates of hysterectomies because of the lack of this conversation around between providers and between women who are beyond the reproductive years or towards the higher end of the reproductive years. And so the roots again lie in the absence of conversations around SRH beyond the reproductive years, and MH could be a great entryway to start some of these conversations early in the life cycle of those who menstruate. So I would say that talking about menstrual health is the gateway to talking about SRHR, but it's almost necessary for SRHR outcomes to be effective. I hope I'm not overstating this, but I just really feel strongly about this. Looking at the flip side, though, I think there's a lot that menstrual health can also learn from the family planning field. I think in terms of just informed choice, somewhere we've gone down the path of being really prescriptive about products specifically. So I think we need to learn from the family planning field on how to offer the right product mix, the method mix, but also offer informed choice in terms of information, and go back to the origins of menstrual health work to really give voice to user needs, and learn from FP on offering full, free, and informed choice.
Thank you so much, Tanya. That was quite interesting, seeing the intersection and the entry points. As a woman, I totally agree with you. We'll move on to the next question. And ladies and gentlemen, and everyone else who's here, please put in your questions. We'll have a lengthy conversation and we'll be responding to your questions as we go. Now, to the third and final question, as we begin to think through how family planning and menstrual health might be integrated across research, policy, and practice, something that Emily will go into detail later on in a couple of minutes after this. What are you most excited about as a practitioner, Dr. Solomon?
Well, I'm to be honest with you, because these two components, family planning and menstrual health, they are so interlinked and they fit well, so that when intervention packages are being fashioned, so that they can meet the needs of both of the client for both the two aspects, that is family planning and menstrual health, it will really be most efficient and cost effective. So in my opinion, this is something which can be weaved together and be delivered as a package, because it really resonates well with the fact that they fit so well with each other, family planning and menstrual health. And it can be done at the individual level, and also it can be done at policy level. Yeah, basically by providing a kind of an efficient and cost-effective intervention package which has both the components, it actually it will reflect a provision of a quality package, because it goes ahead to meet both the needs of the family planning client, and the family planning needs of the client, and the menstrual health needs too. So that's my response.
Thank you so much, Dr. Solomon. And now, Tanya, just some parting words. What are you excited about? I'm sure you've been navigating this space for a while, and given the examples that you gave us, the opportunities for integrating the research and policy and actually programming, what excites you about this?
I think first that these conversations are now actually happening. I mean, 5 years ago, it was really tough for us to even kick some of these conversations off. So, so that's why, I mean, personally, I'm really grateful, but also excited that these conversations are finally happening. But, Dr. Solomon's point of, looking at cost effectiveness and building on investments by both sectors to really enhance outcomes for SRHR overall is something that's really interesting and exciting for me, because till now, I think we've seen a very siloed approach to both sectors, where we're almost competing for the same donors, funds, and so it's time, I think, to look at how the intersectionality can help achieve or enhance some of the outcomes that we are looking at together, rather than competing as sectors. Also, MH, I think menstrual health is largely focused on adolescents and young people as a sector. If we look at policy and programs and family planning, can really help expand this to the larger reproductive life cycle and start to bring attention to reproductive tract infections, menstrual disorders, endometriosis, menopause, everything that's menstrual health related, but towards the later end of the reproductive life cycle. A lot of health issues for women over 60, for example, like bone and muscle health, non-communicable diseases, go back to their earlier menstrual health or sexual health experiences. And so I think we can learn to tackle those issues by having a more holistic approach. And that's what's exciting to me, that that's a possibility that's looking more and more feasible now. And we can look at reaching beyond the usual suspects that menstrual health has looked at.
Thank you so much. And I'd like to thank our two speakers for this candid conversation. As you see, as you've experienced, they're actually talking of their passion, their experience on integration of menstrual health and family planning. Please keep asking your questions in the Q&A section so that we can we can answer them during our plenary session. I would like to invite Emily Hoops, who is going to give us a presentation on strengthening integrated approaches for family planning and menstrual health. Welcome, Emily.
Thank you so much, Irene, and thank you, Dr. Solomon and Tanya, for that wonderful conversation. It makes me even more excited about this topic, which I'm already really excited about. So you heard from Tanya and Dr. Solomon about some of the reasons and the benefits for this integration between family planning and menstrual health. And I'd like to go into a bit more detail about how this integration might happen and what that might look like in programs and policies. So next slide. So this presentation is actually based on some programmatic guidelines that were developed and recently published in the journal Global Health Science and Practice, and I will put that link in the chat. And that work was funded by USAID through the Innovate FP and Knowledge Success projects. Tanya and Dr. Solomon, as well as a few others of my colleagues joining today on this webinar, co-authored this commentary, and we developed the guidelines that are presented in the commentary through our work on the Contraceptive-Induced Menstrual Changes Task Force. So that task force sort of brought together a lot of people from different fields, and it got us talking about how this issue brings together the fields of menstrual health and family planning, and how there are a lot of different ways that they overlap, not just this issue of contraceptive-induced menstrual changes. And so we decided to, in a systematic way, sort of explore all of those different ways that they might overlap. So we developed these guidelines also because we really believe that there's so much the fields can learn from one another, and a lot that we can achieve together. And you heard some of those examples from Dr. Solomon and Tanya. And that's especially because we have shared goals of improving the health of women, girls, and other people who menstruate globally. And this is done often by both fields by tackling some really complicated things, including stigma, misinformation, and complex social and gender norms. And so those are the things that the two fields have in common and can really work together on. Next slide. So as I mentioned, through a set of meetings, conversations, and iterations that brought together both family planning and menstrual health experts, we came up with this list of potential areas for integration. So you heard about some of these a bit, but they include education and awareness, integrated development of family planning and menstrual health commodities and services, integrated family planning and menstrual health counseling, evidence-based family planning methods that rely on menstrual tracking. So this is what Dr. Solomon mentioned about fertility-based awareness methods. Addressing the issue of menstrual status as a barrier to family planning. So this is when in clinics that don't have access to pregnancy tests, often you have to prove that you're menstruating in order to access family planning products. And there are some tools and methods that can be used so that this doesn't happen and so that it's not a barrier to accessing family planning at that time. Another area is addressing the issue or including contraceptives as an option for managing menstrual disorders and pain. And then finally, some sort of bigger picture areas, social and behavior change communications, advocacy, and policy work, which are also all very important. And although we and the experts we spoke to during the process agree that each of these suggested areas of integration show potential, some of the areas have more limited evidence base. So, for example, there's a lot more research to support comprehensive sexual and reproductive health education, while the evidence base for integrating the delivery of products, both menstrual health and family products together, still requires a lot more research. However, we included all of them together in the list because we sort of all agreed that they show significant potential and require more research and interest and further work. So in addition, this is not an exhaustive list. It's just a launching point for this conversation and a launching point for more research and a more comprehensive approach to family planning and menstrual health integration. So this is the starting point, and we're really excited to see where it can go from here. Next slide. So today I thought I'd take you through a few examples from the programmatic guidelines that are included in the commentary, and the full chart will be put in the chat. It just was put in the chat, actually, I see. I'm hoping this will help you understand how the guidelines are organized and give you a better idea of the types of activities that are possible when we intentionally integrate menstrual health and family planning. So these guidelines are meant to be used by a wide range of stakeholders. That includes governments, donors, program managers, and healthcare providers. And as stakeholders begin to design interventions, they should look at sort of these two categories of things and decide where they would like to place their intervention. So first, they should determine which area of integration they want to be working. So that can include improving education and awareness, improving systems level interactions, improving client level interactions, reaching populations with special needs, implementing advocacy and SBCC programs, or strengthening policies and guidelines. And you'll see these are sort of reflect different levels at which you can intervene. And we really use the socio-ecological model to inform this part of the guidelines. And then you need to determine which population you'd like to work with. So that can include pre-adolescents, adolescents, midlife and reproductive years, perimenopause, and menopause. And those age ranges will probably depend on the context in which you are working and the guidelines you're using. And so those are just sort of the broad categories we've used. And this is to take a reproductive life course approach. So we understand that the needs of individuals at different points in their life will be different. And so interventions need to be tailored to those moments in their life. And also understanding that family planning and menstrual health integration can make an impact across that life course and should be implemented for all of these different groups of people. Next slide. So as I said, I'm going to take you through a few examples from the guidelines to sort of give you an idea of what these look like. So here's the first example. Let's say that you'd like to implement a program that reaches pre-adolescents and you'd like to improve their education and awareness around family planning and menstrual health. Next slide. At this intersection, the guidelines suggest that you design a program that includes evidence-based puberty and comprehensive sexuality education. Now, as many of you know, this is not an activity that's unique to family planning, menstrual health integration, but the guidelines set out specific ways that these programs should include information about both menstrual health and family planning together within this type of program, and especially about the connection between menstruation and fertility, which is something that Dr. Solomon mentioned earlier. And this specific guidance on including information about menstrual health and family planning is really important because these aspects are often not included in sexual and reproductive education programs, or maybe one of them is included and the other is not, but it's often not comprehensive enough and does not sort of draw the connections between menstruation, fertility, and family planning. Next slide. Here's a second example. Let's say we'd like to design an intervention for adolescents, and we'd like to improve systems level interactions. Next slide. So at this intersection, we see the suggestion to integrate menstrual health commodities and services into family planning within the health system. So this would include providing essential menstrual health products like pads or cups or even pain medicine during family planning counseling sessions. And this is needed partially because, as Dr. Solomon mentioned, the menstrual cycle can change when you're using certain family planning methods. So for example, you might be bleeding more when you first start using a method, and so you'll need more menstrual health products. And so providing those products during counseling sessions might be a good intervention to test out. And as far as we know, this is an activity that's not really being routinely implemented, but we think it has serious potential to make an impact. And we'd really like to see more research in this space in the future, and we'd love to hear from any of you joining if you have done this type of work. Next slide. As a third example, let's look at people in midlife and reproductive years. And we want to improve client level interactions within the health system. So instead of making a change at the larger health system level, we're looking really at the interaction between the provider and the client. Next slide. So here we see a few suggestions related to family planning counseling, which we've heard a bit about already. So first, family planning counseling, as always, should include information about the full method mix, about all of the different choices of family planning methods. And this should include information about fertility-based awareness methods and the lactation amenorrhea method. And those are both methods that really rely on an understanding of the menstrual cycle, and so can act as a place to provide menstrual health education and education about fertility and menstruation. And the second sort of suggestion for family planning counseling improvement is to provide information about the ways contraception will impact the user's menstrual cycle, which we've mentioned several times. And as Dr. Solomon mentioned, there's a job aid called the Normal tool that can be used to do this, which we put in the chat, but I'll link in the chat again. And that is available in many different languages, including English, Swahili, French, and Spanish. So please take a look at that. Next slide. So let's look at an example reaching a special population and for, again, clients or people in midlife and reproductive years. The special population we'll be looking at is people who are experiencing menstrual disorders. Next slide. So here we see a suggestion to ensure that providers offer hormonal contraception as a part of a comprehensive plan to address menstrual disorders, such as endometriosis or PCOS or many other examples. So this intervention is really important because menstrual disorders are a very overlooked issue, especially in certain contexts. And there are really limited options for managing and treating menstrual disorders. And there are some family planning methods that can really offer relief to these populations to manage these disorders and manage some of the symptoms of these disorders. And so this is a really important point. Next slide. And then one final example I wanted to provide you. Let's look at the policy level, and let's say we're looking at perimenopause and menopause as a population. Next slide. So here we see the suggestion to update family planning, menstrual health, and SRHR guidelines to include information about family planning, menstrual health integration, and especially including suggestions to address contraceptive-induced menstrual changes in counseling. And actually, this example was for perimenopausal and menopausal people, but it really applies across the life course. So policies should address how to integrate family planning and menstrual health across the life course, and give different resources and examples and guidance on how to do that. This should include updating clinical guidance and healthcare worker training to reflect some of the suggestions I just spoke about as far as counseling and providing the full method mix and information about menstrual health during counseling sessions. And actually, a really good example of this is something Dr. Solomon can speak to and talk more about during Q&A, but we've worked with the Kenyan Ministry of Health to include the normal tool, which I've put in the chat, in several of their policy documents and training packages, including their reproductive health documents package, their self-care guidelines, and their orientation package for certain family planning methods, including the hormonal IUD and self-injection. And so that's been really exciting and a really good example of how family planning menstrual health integration can happen at the policy level. Next slide. So I hope those examples give you just a snapshot of the potential impact that comes when integrating family planning and menstrual health. And I hope you can get a chance to look through the full set of guidelines, because like I said, that's just a snapshot. There are many more examples and guidelines to take a look at. And there's also a lot of resources linked on ways, on things that you can use to help you when designing these integration programs. One last thing I wanted to leave you with is a call for research in this area. So as I mentioned, these guidelines are just a starting point. We really need more evidence to understand which integrated models work most effectively. So any program that uses these guidelines should evaluate integration as they are starting to implement these programs. And when appropriate, should incorporate more rigorous research to better understand the impact of these integrated approaches. So for example, some of the research questions we are interested in include how can interventions be designed to improve contraceptive satisfaction and use? So possibly would providing menstrual products improve satisfaction and use of family planning methods? How integrated approaches can impact users' menstrual cycle experiences? Whether co-located service delivery is more effective or less effective than referrals. So should we include menstrual health and family planning in one place, or should they refer to one another, which is most effective? And then also, what type of providers are best positioned to provide integrated services, and how can they be trained to do this in the best way? So those are just a few research questions that we have, and there's a lot more to be answered and a lot more to be done. Next slide. And with that, I'll conclude my presentation by just saying that we're really excited about the work and the conversations happening between these two fields, and we really hope that they can continue, because we believe that family planning and menstrual health integration at all socioecological levels and across the life course has the potential to significantly improve the health and well-being of women, girls, and people who menstruate. Thank you so much. My contact is on the slide there, so please feel free to reach out with any questions or follow-up.
Thank you so much, Emily, and the rest of the speakers, especially for your presentation, which has demystified integration. It was very informative and useful. And now we've seen some of your questions and we'd like to address them. If you have other questions as we answer some of the questions that have come up, kindly please put them on the chat and we'll be able to address them as we go. So we start with the first question, and this is from Rova, and I think it has been responded to, but maybe for the sake of everybody else. In the context of menstrual health, what message should be conveyed to women who complain of not menstruating when using DMPA, despite having been warned of the possibility during counseling? I think Dr. Solomon and Emily, if you want to provide more information on that, you could turn on your mic and speak.
Yeah, I didn't get that one very clearly. I didn't just ask again. Sorry, or it's here.
The
About the
question was in
DMPA.
the
Go on. About
in the context of menstrual health, what messages should be conveyed to women who complain of not menstruating when using DMPA, despite having received counseling of that possibility?
well, yeah. So DMPA, like the other related, methods which have the more or less the same similar hormone, which is basically the progesterone or progestogen. So they do have similar, we can call them effects, and one of them is definitely the issue of not having any menstruation at all. So in the medical terms, they are referred to as being amenorrheic, meaning they have amenorrhea, no bleeding at all for that time they're using. So most of the time, of course, this is a cause of anxiety to the client and maybe the couple, because they are used, the client is really used to get regular monthly menstruation. But then if now they have started the use of the DMPA, and then they realize that they are not exactly having their menstrual periods, and yet they are on that method, then they really worry. Because one of the main worries is that they would wonder, okay, first of all, is this normal? And then secondly, if it is, then where exactly is this bleeding going? Is it being stored somewhere else? Is there a dam somewhere or a tank somewhere where the blood goes? So those are the concerns which have to be addressed. And the service provider will have to be fairly equipped with the right way of providing that message or that information, so that the client can really, anxiety levels can be allayed. So the real answer here is that those are just one of the side effects of the method. There is really nothing wrong about that, but each and every client responds differently to different methods, and therefore they need to be engaged in terms of be provided the correct information, and therefore have the client anxiety levels reduced to normal levels, so to speak. So I think that's my answer to that. So just like other menstrual changes that do occur, especially with the DMPA and other progesterone-related methods, they do cause irregular bleeding. They do cause, in some parts, just spotting. All these should be tackled right from the onset before the method is provided, with proper counseling and explanation that this is really something to be expected. It should be regarded as normal, especially if she's on regular method, and therefore that should be able to allay the anxieties, and hopefully they will continue to use the method. Over.
Thank you very much, Dr. Solomon. Olanike Adedeji asks if there is a list of research questions that you can share, Emily, And are there opportunities, ongoing opportunities that you can share?
Sure. So a lot of the work in this space that has already been done is related to contraceptive-induced menstrual changes. And we have a research and learning agenda with a list of research questions related to that topic specifically, though some of the questions there do relate more broadly to family planning, menstrual health integration. And so I put the link to that, or I will put the link to that in the chat for everyone to access. There's a lot of work that's being done at FHI 360 related to this topic, especially related to contraceptive-induced menstrual changes. We have a community of practice related to this topic, and so I'll put the link to that as well. And that's just a space for people to come together and talk about this issue and develop resources and do work related to this issue. So there's a lot of exciting work happening there. But I would also like to take this opportunity to call on organizations and especially funders to really provide opportunities for more of this work to happen, because we have a lot of questions that need to be answered and a lot more work that needs to be done. So we do have a few ways to get involved, but we really need a lot more, and we need a lot more funding to make that happen. I'd love to hear if anyone else has thoughts.
For Lanike, and also everyone, please. Hello. On this question from Edward Galiwango, and he says, listening to the discussion justifies integration of contraception and menstrual. Several stakeholders in Uganda regarding, are there targeted messages for to help them appreciate this? I think Tanya is best suited to address this question. Tanya.
Thanks, Irene. So I think this has to be
Hello,
the work.
Tanya, are you there?
Hi, can you hear me?
Yes, we can hear you. Irene, I think you're having a bit of issue with network, but go ahead, Tanya.
Yes, we can now.
All right, thanks. So I think in terms of ensuring that contraceptives are available for adolescents, I think the biggest advocacy tool is to look at emergency contraceptive use amongst adolescents, and I think there is data around that for Uganda as well, which can be used to showcase, one, the unmet need for contraception amongst adolescents, but also the need for a provision of solutions for safe sex. So I think just using some of that data, and if it does not exist, to ensure that there is investment in research around generating that data would be key.
I also think emphasizing age-appropriate information and education is important as well. So the intervention, for example, on the guidance I showed you for pre-adolescents versus adolescents versus older people is definitely going to be different and should be tailored to what that age group can comprehend and what the information that they should be receiving.
Thank you so much. From more of a health worker perspective, Paul Ile Busi asks, how do health workers counsel women of childbearing age on the choice of family planning methods with various methods available without missing out on the benefits? let me repeat the question and probably start with Tanya. How do health workers counsel women of childbearing age on the choice of family planning methods with various methods available without missing out on the benefits?
I think, Irene, this might be a question answered by Dr. Solomon or Emily.
Mm-hmm. Emily, would you like to tackle it first before we ask Dr. Solomon to chime in?
Sure. I mean, I'm trying to sort of understand what the question is getting at. I'm not exactly sure what you're asking. If you want to clarify in the chat, but I think, I mean, I would just say that, as we mentioned, when family planning counseling is happening, it should include counseling on every single method, and that includes talking about both the side effects and benefits of each method, and then finding which of those sort of benefits and side effects fit into that person's life the best. And that includes side effects related to menstruation, so whether increase in bleeding or pain or things like that. But we also like to emphasize some of the benefits, or what we call side benefits, of family planning methods. So as I mentioned, it can help with painful periods, dysmenorrhea. It can help with certain menstrual disorders like endometriosis, or it can just help with reducing bleeding and pain so that you can do your daily activities more easily and more freely. I'm not sure if that answers the question, but hopefully it does.
And if I may add to that, I can draw a parallel from the menstrual product world. I think what we also see
Irene, you're cutting out, but Tanya had something to add. Go ahead, Tanya.
Yeah, so I think we have a parallel that we can take from the menstrual health world. So in trying to offer informed choice in menstrual products, at the level of programs, we often see that it becomes lopsided, that one tends to, or health providers or health workers end up pushing products or talking more about the negatives of products that they do not have available with them in terms of the supply chain. So I think ensuring supply chains are also oriented to offering that choice, whether it's through direct provision or whether it's through market-based mechanisms, is an essential part of ensuring that health workers are also not disincentivized to talk about the benefits of other methods or other products in both cases.
Thank you so much, Tanya. And to just piggyback on that, Augustine de Chagme Achigba, I hope I've not butchered your name, but Agustina asks, are there examples of countries that provide menstrual health commodities and family planning clinics for clients? And if yes, are these menstrual health commodities provided for free or at a price? Yeah. Do you have examples that you can share?
I can take a stab at that. So I think just in terms of providing, we have, and this has, I think, not been intentional from the menstrual health world, but more organically from the family planning world to try and make the model also more sustainable and offer solutions to users' needs, is adding mostly sanitary pads, disposable sanitary pads to the basket. And so we've seen, social marketing organizations and also clinics stocking at least sanitary pads for mostly, I think, subsidized distribution is what we've seen, not free. But at least in my experience, I haven't really seen choice being offered in some of these points of access in terms of menstrual products.
Yeah, I agree. There aren't a lot of great examples of that. I think that, like, in humanitarian context, there are a few examples because there are sort of a package or of reproductive health products that are provided, and often that includes both family planning and menstrual health products. But like I said, that's an area that we really need to explore more and implement more programs so that we understand how that might work.
Thank you so much. Ando asks, speaking of funders, Emily, could you share which ones of those are interested in the area of FPRH integration, FPRH and menstrual health integration for programming and also for research?
Sure. So I think Tanya and I have both mentioned that it's frustrating because the funding sources are very siloed right now. So there are funders who fund menstrual health and there are funders who fund family planning, and they don't really work together. And so that needs to change. But as I mentioned at the beginning of my presentation, this development of the programmatic guidelines and the work of the contraceptive-induced menstrual changes task force is funded by USAID, so they do have some interest in this, and they definitely fund both menstrual health and family planning programs. And then also the Bill and Melinda Gates Foundation has recently started to look at this issue and is funding some of our work related to contraceptive-induced menstrual changes as well. So I think that if we keep having these conversations and keep making noise about how important this is, maybe it will get the attention of more donors, and hopefully the funding streams will be less siloed in the future.
Thank you so much. And I'd like to thank everybody for presenting their questions. There's some that we have planned to answer in our next session, and we organize interesting webinars. So now we'd like to hear from you and get your feedback on the guidelines, which has been shared several times by Emily, by all the moderators who are with you on the chat. We have a couple of questions that we'll share using the Mentimeter. To access the question, either use the QR code that is on your screen at the top left, and it'll take you to the Mentimeter, or go to menti.com and enter the code 4650985. This code shall be posted on the chat for ease of access. But if you're doing it from your phone, it's menti.com and enter 4650985. You can click the link on the chat box as well, which has just been shared. And we would like you to include your country in parentheses at the beginning or the end of your feedback submission, because we take a very tailored approach to knowledge sharing. So we understand each region has different needs and preferences for how information is shared. Providing your country helps us take these global guidelines and tailor them for your context. I saw somebody said that they tailored them for Malawi, so that's great. And we'd like to do more of that. So we shall link the guideline again on the chat, and we are waiting for you on the other side of the Mentimeter so that we can start with the questions. Please take your time and access the Mentimeter. And our first question is, how might you be able to integrate family planning and menstrual health and put these guidelines into action in your current work? Please remember to put your country in parentheses as you're answering the question, because we would like to be responsive to your need, or to actually contextualize the responses as we go, or as we create solutions. How might you be able to integrate family planning and menstrual health and put these guidelines into action in your current work?
Thank you,
The link to the Mentimeter is on the chat box. I know we're over 104 participants, but we can only see 6 of you. So please join the link so that we can be able to see your ideas. Emily?
Thank you. So I'm just going to read some of these out and maybe try to make some connections as you're entering your answers. I already see some really exciting suggestions. Here on the left, I see a few suggestions for understanding supplies and supply chains, which is really important to both family planning and menstrual health. And so I think that's really an exciting area to focus on. I see a few examples of working with youth, and one is working with both youth and parent groups in Malawi, which is really exciting. The guidelines do call out parents as a specific group that needs to be engaged in this work. I see some bigger picture examples. So through advocacy and communications, building a case for investment in research and programs, and then also advocating for better funding stream integration. So those things are really important at the sort of higher level to actually make this work at the program level. Let's see, humanitarian settings, integrating family planning, counseling, and menstrual health. I think that's a great example, especially as I mentioned, because often in humanitarian settings, menstrual health and family planning are already being provided, and so they just need to be sort of brought together a bit more. Developing a simple tool for menstrual cycle awareness to use in FP counseling. I think that's really important, and the menstrual health field has so many tools that can be used and that we in the family planning field can use. Let's see, what are some other examples? A lot of work as far as business development and proposals. So we really just need to propose this work. We need to be able to make sure that it's happening and funded. I see some suggestions for the government level, including things in guidelines, which, as I mentioned, Kenya is a good example of that. The normal tool has also been included in several other guidance from countries, so that's a good way to start at least. Let's see, what else do we have? Generating evidences from lived experiences to highlight the issue and the need for integration. So I definitely agree with that. We both need research to show what type of integration works, but we also need more research to illustrate the need for this type of integration, to show that people who are getting family planning services also need to learn about menstrual health. So that's a really good point. Yeah, so I really love all of these examples. I love that there's specific examples to countries. Here's a few from Ghana. There's one from Nigeria. Let's see. I think that it's great that you will share these guidelines with colleagues, with people working both in family planning and menstrual health, because this is really a good starting point, like I said, that can start this conversation. We'll have a recording of this webinar if you'd like to share that. We'll share slides, so any of the resources from today would be great to share with your colleagues. I see a specific mention of contraceptive-induced menstrual changes, so if you'd like to get involved in that work, I've put several ways to do that in the chat. Irene, please let me know if you'd like to move on to the next question. I think we've gotten some really amazing responses, and I'm excited to sort of look at these in more detail later.
Thank you so much, and thank you to the 22 of you who joined this Menti question. There's a second question coming up, and I'd like to ask for the link to be posted again. And the question is, what would you suggest we do to make the guidelines more accessible, understandable, and user-friendly to both menstrual health and family planning practitioners? What would you suggest we do to make the guidelines more accessible, understandable, and user-friendly to both menstrual health and family planning practitioners? Please submit your answers to this, your suggestions, so that we can take them into account when we are improving or changing up things for your use. The link is on the chat box. Please do get into the Mentimeter and provide your answers. Emily?
Thank you. I'm going to share the link to the guidelines again in the chat just so that people can look at them as they're answering. I And just as some context, we provided this sort of table as a part of the publication, but it's definitely text heavy and not very easy to use. So we wanted to create a version that is much easier to use for people, especially in the field. And so I like the suggestion of a digital format. That would be really a great way to present it for many people. Make it more visual. Like, yes, it's very text heavy. Making it more visual would be great. More concrete examples and case studies. Yes, we'd love to collect those. If anyone has examples or is working in this, we'd love to hear that. We have a few of our own, but like I said, this work is very new and often not happening. So we'd love to get more from you. So I see more suggestions for examples. Use electronic guidelines and also share them to practitioners. So sharing these guidelines in many different spaces. So like, for example, the World Health Organization site, the training resource package, I think that's a great example. And more calls for visuals and infographics. I think that's well taken. I think we need to make this a little bit nicer to look at and easier to use. Translation into French and other languages. I definitely agree that needs to happen very soon. And hopefully we can make that happen soon. Checklists are a good way to sort of do it. I think that would be helpful. Multiple languages, again, digital format suggested again. Involve ministries, community health workers, involve the people who are going to be using these to do it. I think that's a great suggestion as well. More visual and less technical. I definitely agree. We don't want the sort of publication version to be what people use in the field. We need it to make it better for people and easier for people to use. Advocacy tools. So suggestions for other things that we might need to actually make this happen. Yeah, so I think there's a lot of great examples. We definitely need to just make it easier to look at, easier to use, make it more accessible by bringing in other languages. I think those are all great, and we'll definitely consider those as we continue to make these guidelines available to more people. Irene, back to you.
Thank you very much. And thank you all for your active engagement and participation in this webinar. We're very excited to start this conversation, and we promise you that we shall continue the conversations as we go. I would like to thank our speakers today. It has been an interesting almost 90 minutes. We're happy that we have kept time. And in addition to this, as I said, knowledge success helps you to learn more, share more, and do more. And therefore, we have created a collection in our repository. It's an online repository called FP Insights. And a link of this shall be provided or has been provided already. It's Emily's collection. You can go in there and be able to access all the resources that have been shared, and also share some of your resources on menstrual health and family planning, showing examples of the integration.